Gerda noted that, in Iran, a research paper in Scientific Reports stated that ambient PM2.5 related deaths were estimated using the Global Exposure Mortality Model, GEMM, and using ground-monitored and satellite-based PM2.5 monitoring. The study concluded that based on our findings and other studies, the residents of all provinces and counties of Iran have been, and continue to be, exposed to health-damaging levels of ambient PM2.5 over the past 3 decades. Although it is, in Iran, recognized to be a serious issue by civil society, researchers and policymakers, there has been little progress in reducing it. Levels of PM2.5 remain unchanged according to the website stateoftheglobalair.org. Despite this, the Iranian Department of Environment, DOE, released a revised National Ambient Air Quality Standard, NAAQS, in August 2017, in which the annual and daily PM2.5 standard increased 12 and 35 micrograms per meter cubed respectively, relative to the previous NAAQS, 10 and 25 micrograms per meter cubed, which was based on the World Health Organization, WHO, AQG 2005. Since then, the WHO has further lowered its PM2.5 AQG based on the latest scientific evidence and offered guidance to governments seeking to reduce air pollution exposure and attributable mortality, including short and long-term measures to reduce ambient air pollution and its health burden that have been successfully applied in other countries to reduce ambient air pollution-related health impacts and corresponding economic loss. See who.int/news. Such approaches include shifting to clean fuels, transportation reform, and reducing traffic emissions from vehicles and other major sources. Their implementation poses challenges in many lower middle-income countries, LMIC, where economic development and poverty reduction relied on heavily polluting economic activities. Our study has some limitations. First, AQMS were not widely available in all 429 counties of Iran, and we used the estimated concentrations of ambient PM2.5 based on neighbor stations. Second, the national-level baseline mortality data was used in Iran. Third, some of the data required for health and economic burdens were borrowed or estimated from the international studies.